Thank you very much, everybody. Welcome to the Health and Wellbeing Board. We're just going to start with some new appointments. If you haven't been here before, it's lovely to see you. Our Health and Wellbeing Board is a collective. Those people around the table are asked to think, as we go through each item, about what your organisation and what you can do to change and move forward with the issues that we look at. I like to remind people it's not a scrutiny committee. This is about collaboration and focused on the way that we together can continue to work to reduce health inequality. So I'll just let Stephanie do the appointments, say a few things about some of the new people who will be here on a permanent basis and welcome our visitors. Okay.
Thank you, Councillor Murray. So the first order of business is to appoint Councillor Murray and Jack Packman from the MVA, who unfortunately has had to give his apologies today, to the chairperson and vice chairperson post for the 26-27 municipal year. Is that agreed? I think we have the usual people on the board as per normal, but we do have a new person from Health Watch. We have Tim Benfield here, and we also have Gillian, who will be an ongoing invitee to the board.
Okay. And Claire is here because we want to make sure the voluntary sector are involved. So Claire's here from MVA. Jack Packman, their CEO, will be our vice chair, but we've agreed that Claire can be a formal substitute, and you are very welcome, Claire. We've got some visitors today for our item on neurological disorders, Dr. David Oliver, Julian, Martin, and Phil. So you're very welcome, and we're looking forward to hearing from you. And we're just going to add in a little bit to the joint health and wellbeing strategy. David Whiting's going to do a short presentation to update us on neighbourhood health, because we need to keep that live with this board. The board itself will have to produce a plan in concert with everything else that's going on. So it makes sense to take the opportunity just to refresh and revise ourselves about where we've got to, because neighbourhood health is developing all the time. The other thing I wanted to say, delighted that on the 4th of June we opened the James Williams Health Centre in the Pentagon Centre, thanks to ICB friends from MCH, who got that together with Medway Council off the ground. It was a really lovely occasion and a fantastic facility that I hope will be a leading light in the neighbourhood health landscape and filling up as we go with therapists and co-located friends and experts from across the public services who can help that particularly challenged population. And as I said at the opening, the standards there are the standards that we demand for Medway. Things are patchy at the moment. We know that. There's an acknowledgement in this board. But it's really great to be able to say that's what we want for every single person who goes to a health centre. And it's really, I was there last week for Carers Week and for Loneliness Week, which coincided. We were outside of the health centre with all of the networking partners, and it was attracting a lot of attention from the public. Remember, neighbourhood health is working on health and all of the social determinants, and that's why that partnership working in that particular facility is so important. So starting the new Health and Wellbeing Board for this municipal year on what I hope is a very positive note, and looking forward to hearing from all of you in our discussion. Now, we've got one more person who is new today. That's Yasmin Vaughan. I want to give a wave, Yasmin, in case people can't read your name. Yasmin's from Adult Social Care, and she's head of Early Help and Prevention. We've got our Assistant Director, Jackie Brown, working on an internal secondment to really tackle the adult social care strategy, to make sure that it comes into place and to get to grips with supported living and with the way that we manage the finances of adult social care going forward. We are, as every authority is, challenged with costs waiting for the outcome of the Casey review that at the moment, I have to say, has done nothing but cost us money in terms of what has been said about safeguarding, important though it is. So Jackie's team, her heads of service, are working across some of the external partnership meetings that Jackie has had. That's great development for them, and I'm sure that you'll all be very pleased to hear from Yasmin, who has made actually a fantastic contribution since she came to Medway Council. She is a very modest person, but her ideas as we modernise and refresh adult social care have been really impactful so far. So I'm sure that she'll make a good contribution this afternoon. Okay, thank you. Apologies from Jackie, but I've explained that Yasmin's here, from Kelly Cogger, from Siobhan Callanan, from Medway Foundation Trust, from Jack, but we know that Claire's here, from Martin Riley, from MCH, and from Councillor Curry, and an apology from Leanne Farrack, our Director of Children and Adult Services today. So Yasmin's filling big shoes. She's here for everybody. Right, I'll turn now to the record of our last meeting. To you what we looked at last time. We reviewed our themes for performance indicators because every meeting is themed from the health and wellbeing strategy. So we had, and thanks to Scott Elliott for putting that together, an overview of all of the things that we have been working on, and heard about our new therapeutic alliance, taking care of the mental health of young people. Went live on the 1st of April and seems to be, I'm pleased, going very well, and over time we'll hear from them directly in how they're doing. We had a look at the Integrated Care Board's Recovery and Transformation Programme and the outcome of the formal staff consultation. We had taken part in that, and we welcomed Dominic from the ICB, who is going to be our contact on the Health and Wellbeing Board, and Dominic kindly took us through that. We had an update on neighbourhood health, and we're having another one today. By routine, because we have to, we looked at the Better Care Fund. We've had approval for our use of the Better Care Fund this year, and that has taken its place in the budget and giving us the opportunity to continue to work on innovation. It was nice to have friends from the police here and Councillor Patterson thinking about the way the Community Safety Partnership, Strategic Assessment and Community Safety Plan impacts on health. And that was, I think, a very valuable discussion. We picked up some things that we can help with there. And then we had an excellent report from the Corporate Parenting Board, letting us know how we are getting on with a lot of involvement from Councillor Price, who's here today, with our children in care. Then we looked at the work programme. Any comments on anything that I've just talked about in the minutes? Okay, thank you very much, Councillor Jones. Prescient as usual. Yes, so everyone else is happy to agree the minutes, are they? Thank you. Yeah, okay. And so we'll move to our first substantive item, the Joint Local Health and Wellbeing Strategy. And I should have, as Stephanie has asked me, asked you if you've got any declarations of interest, disclosable pecuniary interest and other significant interest in any item on this agenda. Okay, thank you. Right, so now we can move to the meeting. That was Mark putting me off by agreeing things too quickly. Okay, thank you very much, David. I'll pass over to you.
And David. Thank you, everybody. So in front of you, we have the paper Many new members may not be aware we have the joint local health and wellbeing strategy. It was created a couple of years ago. We're sort of midway through the strategy. The strategy has 4 overarching themes: healthy and longer lives for everyone, reducing poverty and inequality, safe, connected, sustainable places, connected communities and cohesive services. Those priorities were based on a very thorough piece of needs assessment data. We keep updated regularly, and a heavy piece of consultation with residents and stakeholders to what are the important issues for residents. Last year, we followed the pattern of identifying each of the themes and having a deep dive into some core issues that relate to that theme. Theme 1, for example, is very, very broad. You know, we could debate that for days on end. There's many aspects that sit within healthy lifestyles. Now, what we have within each of the themes is a set of indicators. So indicators are different to targets. They are there to indicate how much progress we're making against a certain theme. In the Appendix 1, you'll see a set of indicators, Appendix 1, which is in your full notes, about page 22. So we have a set of indicators related to the goal. These are indicators which are overarching. They are the things which affect the big ticket items in terms of public health, you know, life expectancy, under 75 mortality from the biggest diseases and killers, admissions, hospital admissions, care provision. It does that not to say these indicators are the most important thing when it comes to the overall goal and purpose of the Health and Wellbeing Board, but they are a set of indicators that are regularly updated. We can benchmark ourselves against our neighbours, we can track our progress, and we're quite confident the data source is either the lesser of the evils or the most reliable thing that we can benchmark ourselves against. And as you'd expect, and there's a key suggestion in the top right-hand corner, green is good, red is worse. Some of the indicators are greyed out because they're either not comparable across our peers or for some reason the data source changes, but we do try and reflect these and change them. And then as you just move down the page into page 23, 24, 25, 26, each of the priority themes has its own set of indicators which are meant to reflect the overall overarching theme. So as I mentioned, in priority theme 1, which is around healthy lifestyles, we have a big set of indicators around things like obesity, stop smoking services, but also quality of life, mental well-being, which are normally annually refreshed data sets, some more valid than others. With approval from the board, what we'd like to do is repeat the themes we did last year, whereby September, we'll start off by looking at the overarching goals and purposes, use that meeting to theme that and talk about the things which affect all of the themes, might be the built environment, maybe a manner of things, mum at work, you know, looks at health inequalities more broadly, and then moving through the next meeting, so next meeting in November, focus on theme 1, February's theme 2, and then really drill into that. It helps us as a board, hopefully, look at things in the realm, because there's an overlap between certain conditions and certain outcomes. But also helps presenters as well come in and say, actually, when active travel does link to the climate change, that links to aspects, which hopefully works quite well. As you will see from the tartan rug and the different colours, we are performing better on some indicators than not. So again, this gives an opportunity as well for board members to actually really keen to look at a particular indicator, percentage of physical activity adults or other aspects. And then it gives us a bit of a longer lead-in time to ask different partners to come in and present that. It is a much richer health and wellbeing board if we have partners come and present it rather than just the public health team talking about our small aspect of the world.
Thank you very much, Scott. So hopefully everyone can see we've set out the way that we're going to look at the priorities in the Joint Health and Wellbeing Strategy for this year. And please, if there is a particular element of the theme that you would like us to look at more closely, or that you want to invite somebody to give that kind of extra insight into how that theme is progressing, then I'll be very pleased for you to contact myself and Stephanie, and we'll make sure that we get the right people when the time comes. I think it's also worth saying, Scott and David, we're about to start our health and wellbeing survey again, aren't we? A very rich source of data, commended actually across professional circles for its depth, reach and, if you like, capacity, because we spoke last time to over 3,000 people, and this is done in several ways, including direct engagement and door knocking. And it really provides us with, if you like, that other side of the coin. How are people feeling about the things that we hope that we're working on through the health and wellbeing strategy? And again, over time, in this year, we'll hear how that's going. Any questions, please, on either the order of the priorities, because obviously today you're being asked really just to approve the forward plan and have a look at the tables to give an indication of anything you think that we should be particularly focusing on when the time comes. Andrew, please.
Thank you, Chair. Can I just confirm, we're now in the third year of the plan, is that right, Scott? 23 to 28. I just wondered, in terms of the understanding the progress we're making, this document, Appendix 1 that's attached, it's very difficult to see what progress we're making. And I don't know about anyone else, but you come to these meetings hoping to make a difference, but if you can't see the progress that's being made, then what's the point? What's the point? I mean, I'll give you a couple of examples. Addressing childhood obesity has been something that's we're talking about since before I was a councillor, but it's still worse. And I wonder, Chair, if there was any way that some of these meetings could be a little bit more, not only about doing the themed, looking at the themes, I think the themes are important, but actually hearing about what we've done differently if we're not making any progress in key areas. So another one I'd like to highlight is access to GPs. And so they're just two that I picked up because, I'm just aware of those. So it'd be really interesting because for me, just to sit here and receive another themed report that shows no progress or shows little progress, or we're hearing about another change in strategy or another recovery plan sort of defeats the object of trying to improve the health of our population, and especially given where we are with the neighbourhood plan, which is a massive piece of work, and understanding how we're going to see improvements and have those conversations to make sure things are improving. Thank you, Chair.
Well, thank you for those comments. I did at the beginning ask if there was something that you particularly wanted to look at, and you've mentioned childhood obesity. I'm sure we'd be very, very happy to do that. It's important, and it is something that is difficult to overcome, but there's lots going on, so it's worth doing as you say. You will know, I think 2 meetings ago, we had a very in-depth analysis of the GP landscape from Sukh Singh, and he will do that again this year. And as part of the Health and Wellbeing Survey, we'll be hearing from people about how they're feeling about GPs. It goes to say, though, Andrew, we have got 14 new GPs in Medway. Only 5 of them are full-time. The James Williams Health Centre adds another training practice to the roll call of about 9 now, which is helpful because that means that new GPs have got some really good facilities to come to and learn. And it's for all of us, including you, to encourage them to come along. So with that, I'll pass over to Scott.
Thank you. So the summary slides that if people have seen this the first time, they do just give a picture. It's not the best story to be told. So what you'll see in the next theme meeting, for example, so in the goal and purpose slide, so each indicator, there will be a summary of the trend line. So you can see if it's got better, worse, indifferent, whether it's marginal or massive. We'll include confidence intervals to show that we can be confident that's an actual change or different to our neighbours. Across the suite of indicators, I think it's really fair to reflect we're making some really good progress on things. So our smoking prevalence, for example, is incredibly low. It's the nature of the board and the scrutiny and the people that are here that want to improve things. We often do bring the more negative things, and we say, actually, that's a red indicator, let's talk about them. We could very happily bring other things and say, this is really good progress from the discussions happening in the Health and Wellbeing Board or the work of a partner, looking at things like active travel levels going up or down. And I think that's that balance we talked about at the pre-meetings as well. We do often tend to focus on negative because it's about improvement, about moving things forward, but very happily bring some of the green indicators that we've done very well and share the praise if that's what people want to see. Absolutely, in terms of there are indicators which are really stubborn. Child obesity is a really good example of a stubborn indicator. There hasn't been much change, so we've seen the raw data. I've seen the raw data that will get published in November, National Child Measurement Programme data. as you'll be aware, there's indicators like that that are very influenced by macro factors, economic factors, deprivation factors. They are influenced by things outside of the immediate control of the Health and Wellbeing Board and Public Health team. But we need to own some of those challenges, and I think exactly right. So every paper we aim to bring that, okay, so it hasn't moved, but this is the stuff we've been doing to try and make it. And you could reverse that conversation and say, it could be even worse if we hadn't done all these kind of things as well. So again, it depends on the kind of the spin, the narrative that we want to kind of put on those aspects. But really happy to bring any of those. And if there's a particular area of focus, again, it'd be great to bring some areas and do celebrate what our partners are working on, things that are showing really positive movements.
Thank you, Scott. And I think the benefit of looking at the greens is that there's learning about how we've made the indicators move. So I've got Celia, please, then David, then Eddie, then Dominic. So Celia, thank you.
Thank you. So I just wanted to say I think it's a really clear visual to get a really good sense check of where we are all across a number of indicators. And I think that's really positive. The colours, you know, you can, without drilling down into detail, you can actually get a real sense of what the picture looks like across Medway. I'm assuming, Scott, there is a document somewhere which says where the metrics are coming from. So, you know, in terms of, say, pupil attendance and things like that. And I absolutely understand that when you look into a report, when we go into these areas, you'll see the trajectory and how that works. But I think it's really effective. One of the things that perhaps is helpful then for future reports coming to the board about any bits of activity is if they could clearly identify which of these they are supporting towards, because they're not one thing that addresses all of these things. So I'm just thinking in terms of, I've got the SEND reforms coming up, well actually a lot of that links in with this, and we've got similar indicators, so just being really clear where those connections are when we bring reports to the board.
Thank you, Celia. That's helpful, a one Medway approach, and we do need not just to think about the way that things knit together, but also the way that each different part can help the other. And the SEND reforms are a really good example of that. David.
Yes, so just thinking about sort of the broader context, yesterday I was at the South East Public Health Conference, and there was a keynote speech by David Buck from the Health Foundation. And he looked at the last 30 years of work driven by central government to reduce health inequalities. So he looked at the policies that were produced, actions that were taken, legislation that was introduced, etc. And looked at how long it sometimes took to be able to demonstrate the effectiveness of some of these things that have been put in place. So even though they were able to be effective potentially within a relatively short period of time, it takes quite a long time for the evidence to come through to demonstrate their effectiveness. So one of his conclusions from this sort of 30-year analysis was to don't lose the bottle, sort of don't get afraid and keep throwing things away if they don't change something within a short period of time. You've got to believe in some of these things that you're doing and wait for enough time for the effectiveness to be for it to be possible to demonstrate the effectiveness.
Writing there, it sounds like a perfect read for you, Andrew. Eddie, please.
Yeah, actually, before I was going to say, that's a very important point I think David has said. We do live in a world now of immediate gratification. It's changed in my lifetime. We now send out an email and a text, and we expect to get information, even detailed content, immediately. So I can include myself in this. I need patience to wait. So if it's going to be done properly, then obviously it takes time to filter through. But I do think gaining that knowledge, that information, the positive outcomes, I really would like to encourage Scott to do that, not just because I want to know, naturally curious, but I have been asked about the role of this committee. And if I was to say, we look at reports and we discuss it, some people may think, talking shop. If I say, on the other hand, we are a forum where we can encourage each other, enable each other, help to focus the mind and focus on what we're trying to achieve. And here's proof, I think that would be a really, really useful thing. So please do. Thank you.
It's important, actually, you're right, for everyone on the board to be ambassadors for the board and its work, Eddie. Dominic, please.
Thank you. So yeah, just first point, I really agree with the point around trends, and we can probably do that in the more detailed discussion, because the sense is, and we've all done this, haven't we, sitting around board tables, there can be a false assurance with a green, when actually the trend might be going the wrong way, and you just need to make sure, don't we, that we're looking at the right things. A point about pathway. So I'm looking at some of the summaries around hospital admissions for cardiovascular and respiratory. And we're doing a lot of work with primary care, because what's really important is the proactive early identification, which obviously impacts here, but we need to reflect, I think, on what we do earlier in the pathway. And just my final point, just to share, and then we can perhaps agree how we move forward. As the ICB, and I've mentioned it at the last meeting, we're really keen to get more proactive and a look ahead in terms of commissioning priorities. And we're taking to our board in July the 21st, I know the date's in my head, a draft set of intentions which will then trigger a period of engagement with partners and the public over the summer, to then come back to the board 21st of September with a more definitive set of intentions. And there is a clear relationship and interface here, and I'm just proposing that I don't know whether we've got a meeting in the summer or whether it's the next one, September, but me and David had a conversation about whether there is a dedicated session that we could perhaps pull together to talk about, because I think there is some really close alignment. So we'll be talking around big challenges around CVD and diabetes, and so how it might be helpful to have that conversation around the intentions and take your feedback into the next process. So I just wanted to put that out there.
Thank you. And look, I think it might be perfectly possible for us to arrange a special session, just as we did when we first heard about neighbourhood health, and had a working group seminar style thing. So if we can do that sometime in August or in very early September, we'd be very happy. So if we leave it that's a recommendation from you that I don't see anyone dissenting from, Scott's going to speak in a minute, then that can constitute the board's formal part of that consultation, actually.
That'd be good.
I'll just take Scott before I take Mark Jones, because you were coming back on that, weren't you?
Just one really, I'm glad you mentioned the hospital admissions. So it's a good indication, when we see the full slide deck, all those indicators that are green on the right-hand side of page 22, almost none of them were green this time last year. So that's an area of focus that's happened and a big improvement across the system. So that's an example of something which is great to celebrate. But equally, so if your hospital admissions get better, and they can reduce, there's a good chance, as David said, it might be 10 years, might be 5 years, might be 30 years. The thing on the left-hand side, mortality rates and certain things, you start to see those things. So they're good indicators that move through, but that's definitely an example of when we've seen that shift. None of those are green, I don't believe, on the right-hand side this time last year.
I think absolutely the insights that we've had working with Sir Michael, that's why he says things take 10 years, isn't it? Because that's about as long as it takes to turn a result and to arrest anything that doesn't seem to be working and change direction. So that makes sense. Dominic, if you're happy to liaise with Stephanie, we will definitely do that. Thank you for that idea. And I think it's very encouraging that the ICB are thinking about commissioning priorities before they actually commission things, if you don't mind me saying. Right, Mark, please.
Yeah, I agree with all that, Chair. I wanted to look at priority theme 3. I find all of this quite useful, including the passages which the last speaker referred to, but let's focus in on priority theme 3. It says at the top line, the strap line, in priority theme 3, compared to England or to a goal, we hope that England and goals are a correlation, indeed, in the coming weeks. But what I wanted to focus on was some of the headings, because I think that in terms of air pollution, public green spaces, violent crime and what have you, these are the very things we should be looking at. I wanted to question, though, what was meant by waste. Is this a recycling objective? Do you know? Is there anybody here now who can answer that question? Thank you.
Back to you. Are you waiting? I mean, I think I just would remind you, Mark, we looked in the community safety plan and prior to that at serious injury on the road, because that definitely, I'm afraid, Medway is an outlier on that, and heard very clearly, in some ways it's related to the number of small roads we've got where there's just a greater prevalence of accidents, and our lack of motorways, quite what we do about that is, but I think, you know, the awareness that the police and the highways experts gave us mean that partly some of the education work we've been doing, the initiative we had at the beginning of last academic year for every secondary school about road safety are definitely part of that, but, you know, we will be look under that priority to see how we're doing and what we can learn from where things have got better. Are you okay, Scott, there?
Thank you for filling. It is the percentage of household waste sent for reuse, recycling and composting. So that is as a percentage. So Medway's figures has dropped over the last sort of 5 years consistently. It's sort of small uptick in the last year though. So yeah, that is, and that's a good example. That's one indicator of waste. It's not meant to be the be all, and if you chase the indicator, you often miss the whole point. So you choose an indicator which indicates whether something's going well. So healthy lifestyles might choose child obesity, but if you just focus on child obesity and neglected smoking, for example, you probably won't improve health and well-being. So yeah, that is the single indicator for that one. And you'll see the full list of these, each theme, so you can see the data source and the trend line if you want.
Thank you, Scott. So with the clear indication that as we come... Oh, sorry, Adam.
Yeah, I was just going to ask under priority 3, because we're quite well served in Gillingham North for green spaces, but there's two separate indicators there. One is access to green space doorstop standard, and it says that we're worse than average, and then a line down that says access to green space local standard. I just wanted just a technical point, what the difference between doorstop standard is and local standard. Because obviously we seem to be similar for the local standard, but not for the doorstop standard. Thank you.
Thank you.
I think there might be new indicators that have come through. They're not on the... they're not on,
No, and Scott... No,
we'll find out for you.
Yeah, we'll come back to you. I think it's related to the local plan. And I think you'll probably find that's right, Scott, about having a green space within walking distance. That comes through for every household, and we've particularly focused on it in the local plan because of the amount of apartments that are being built where access to outdoor space obviously is different and needs managing differently. But we'll come back, Adam, good point, so that we understand that when we get to priority 3. So, with that and the assurance of the detail coming in each of the priorities and the proposal, that I think that's very helpful, Dominic, to for us to have a look at the commissioning priorities in the context of the joint health and wellbeing strategy. Is everybody happy to agree the recommendations? Okay, thank you. Now, David's just going to do a little bit, a bonus feature on how we're going along with the David Whiting, that is, Professor Oliver there, how we're going along with neighbourhood health, just so that we keep it live, because we have got a deadline, although the deadline has moved considerably from March, which was the first deadline we had for putting the plan together. And indeed, so has the Health Secretary moved in that time. But we'll cross that bridge when we come to it, I suppose. Anyway, David, thank you.
Right, thanks very much. So just as a reminder, neighbourhood health is a sort of fundamental change in approach to delivering care, shifting from acute hospitals more to the community and to primary care. And it presents a real opportunity for us as a system to do things in a different way that is more efficient, better for the system, and ultimately, and most importantly, better for residents and for patients. We've got to find this tricky balance between, an important element of neighbourhood health is to have a very local focus, so the needs are addressed based on local need. But there's a real danger that you could end up having a patchwork across the whole of the area, and this is the whole of Kent and Medway, because we're a Kent and Medway system, could have a real patchwork where things work in one way in one place, you go somewhere else, it works in a different way. That would be confusing for staff, it'll be confusing for residents and patients, and it'll be inefficient. So we're looking for ways to structure the development of a neighbourhood health plan that makes things applies a consistent model across the whole patch, so things work in a consistent way, but still is able to respond to local need. There is a small group of us that are working on a plan to develop the plan. We need to have a Kent and Medway neighbourhood health plan, and that will be particularly important for the ICB because it's got to cover that whole patch. But then we need to have a neighbourhood health plan for Medway and a neighbourhood health plan for Kent. But then we've also got, within the Kent and Medway patch, 9 multi-neighbourhood areas and 45 single neighbourhood areas, and those are also each going to have neighbourhood health plans. So we need to do this very carefully, and with the way that we are planning to approach it at the moment is to have a core structure that is consistent across all the plans, and there will be a sort of the core element, the ICB element, that'll be the same across the plans, and then there'll be the localized elements for each of the individual plans that pick up on the local priorities, and so we can get the balance between having a consistent approach, but also having that local responsiveness. We are aiming to be sort of clear about this approach by the time of the July commissioning intentions for the ICB, and then we'll be doing engagement work running essentially alongside the engagement the ICB is going to be doing around its commissioning, so that the neighbourhood health plans will be ready to inform the final sign-off of the ICB commissioning in September. That is the plan. Just one other thing to update you on. Today there has been, in fact, it's still ongoing, an event on neighbourhood health led by the VCSE. So this is not the ICB running an engagement event with the VCSE. It's a VCSE event at which the ICB and local authorities and others have been invited. So I was there this morning. Up until the point that I left, I thought it was a very, very good meeting. There were some really good presentations and conversations. Opened up by Jane Howard, who used to head up Medway Voluntary Action. Jane set the overall scene. Then we had Adam Doyle from the ICB setting the ICB context, giving us a very clear, stark picture of the challenges within Kent and Medway, both from the perspective of outcomes for patients, but also the financial challenges. And also his thoughts on how the VCSE can get involved in neighbourhood health. Anjan, my colleague from Kent, Director of Public Health in Kent, outlined some of the tensions that he saw in neighbourhood health. I talked about the Marmot Place work that we're doing in Medway and how that feeds into neighbourhood health. And then we had Ed Waller talking about commissioning and how it works, and then his thoughts on how the VCSE can get involved and get engaged in the commissioning component, so how they can be influencing the commissioning process and what gets commissioned and how it gets commissioned, and also how they can get involved in being commissioned to deliver services. So it's an ongoing piece of work. There are quite a few moving parts, but I do think it is a really exciting opportunity for the system. And I think we are all, as partners, working working well together to make sure that it comes out as a joint piece of work. I'll finish there.
Yeah, thank you, David. And I think we have got actually a good visual that will circulate to the board so that you can sort of see a visual representation of the way neighbourhood health is intended to work. And just as we're going to do in the next item, I think one of the priorities for the board is to make sure that we know that where different elements of the service have got a place. So if we think about some of the things that we've looked at, for example, women's health, we're looking at neurological patients, you know, where somebody might go if they need fertility advice, where somebody might go if they need contraceptive advice. You know, the GP's surgeries have not gone away, but what we've got to make sure is that some of these things that have got bigger picture reach have got a place in neighbourhood health and people know where they are and how to access them. And I think that's going to be critical. That's why it's prescient today to be hearing from our neurological patients, because what I don't want to, you know, accepting that there will have to be commissioning priorities, we want to make sure that the landscape fits everybody's needs as best we can. So I think it is something to be optimistic about. There are challenges, there are tensions. It's not easy. If Siobhan was here, I'd be saying the same thing, to pull consultants out of hospitals and get them to work in the community, actually. But you know, it's not impossible. And we have to regard those challenges as surmountable and negotiable, I think, as opposed to, you know, throwing our hands up in despair and saying, oh, they'll never do it, therefore we won't, and, you know, letting the whole thing collapse. I am very aware from a political perspective, because, of course, this is where this has come from, although at the early consultation, the most commonly thing said to me was, we're doing this already. I do accept that there's nothing new under the sun, but it is a way of configuring and planning for the system to try to bring healthcare closer to people. And I think for that we have to regard it as well-intentioned and something that actually is desirable, because specialisation of conditions has resulted, and Chris Whitty talks about this a lot, in a situation where we send one person to lots and lots of different places if they've got co-occurring conditions. And that actually might have gone as far as it can go. And we need to pull back a bit. Andrew, please.
Yeah, just a very quick question. David, I'm sorry, I might have zoned out a little bit, but I didn't hear patients being mentioned, and the people who have to pay for all of this through their taxes. What involvement are they having in the design of all of this? You talked a lot about small groups of partners, and I think I've mentioned this before. I think we need to be very careful that this is not done to the population. The population is taken along, and I really like the idea of you said we've done, not here it is. I mean, when you mentioned 45 single groups and 9 double groups, and the chair talking about people need to find where they go get this bit of advice, all of this, you know my opinion on this, GPs used to do, this used to be, the GP used to be the key partner in your healthcare. Now that's obviously changing because complex conditions and everything else. But actually for most people, they just want to be able to access good quality GP care. So my question is what point are we going out to the population in Kent and Medway to say, here is the plan, let us have your feedback on this plan. And when I talk about the population, it's not the groups that always contribute, it's getting down to individual patients and hearing their views on all of this. Thank you, Chair.
Yes, so that's something we're going to need to do, fit in probably between July and September, between the sort of the initial thoughts around the commissioning intentions and then the final sign-off. So that'll give us a window to do that. But you're absolutely right, it's really important that we do that. And just to come back on your point about sort of the focus on the GPs, Adam talked very clearly this morning about the fact that in Kent and Medway there tends to be, you go to the GP and then go straight to hospital, and there's pretty much nothing in between for a lot of stuff. And so he's talking about a 4-tier system. So you'll have the GP, have primary care, and getting much more clarity around what is available at primary care level, and then having what's currently being called intermediate care, and then the acutes, and then, can't remember the top. You know, right. Anyway, having 4 levels. But he was very clear about us needing to be much clearer about what is available at what location, so it's easier for people to navigate the system.
Sorry, just one comment. We're going to consult with people during July and August, when a big chunk of the population's on holiday. The chair will know we don't campaign in July and August for a specific reason. To go out to a wide-scale consultation, if we're serious about talking to the population, July and August, I think, is probably the worst time to do it. Thank you.
I agree it's difficult. We are slightly sort of hostage to fortune in that it's taken a while for the guidance around what neighbourhood health should look like to come out, and we do need to get cracking on it so that we have enough in place by September so that it can inform those decisions made in September, because that then determines rather what will actually start happening in April 27.
We'll make sure that we have a look at your holiday schedule so you can be involved, Andrew. Don't panic. Don't panic, yeah. Right, so thank you very much for as I say, a bonus feature there to keep our minds on it. That comes in with what you've been talking about, Dominic. We'll definitely make that other opportunity, and you know, I'll arrange a one-to-one with Andrew if he's on holiday for any of these situations. Yeah. Okay, so everyone happy to accept those recommendations, and thank you to David for just giving us that insight. Okay, good. I'll take that silence as assent and move on. Thank you very much to friends from Medway Neurological Network, leading us today, Professor David Oliver from the University of Kent. And this is a very good example, and particularly for Dominic's ears, of the way that we need, you know, to make sure that particular groups of people with particular needs are well served by neighbourhood health. You're being asked to note the content of the presentation, think about how we can make sure this is woven into neighbourhood health plans, and with that, David, I'll pass over to you. David has got a presentation that's on the agenda. So,
thank you very much indeed. I'm a retired consultant in palliative medicine. I was at the Wisdom Hospice from 1984 to 2016, but I've always had a very special interest in neurology, and although I've got University of Kent, that's mainly because my slides were easier for that. But we are here as the Medway Neurological Network, and Phil and Julian and Martin are here representing that. Who are we? Oh, it was working earlier. Oh. Yep, an umbrella community support group, really launched 11 years ago nearly. The aim is to be the voice of those affected by neurological diseases and to be a single point of access. We have a mission to defend and improve the quality of health and social care services available to neurological patients, to campaign for improved services, to provide and promote support services such as Skylarks and Neurocafes, which I'll mention shortly, to raise awareness about neurological diseases, particularly rare neurological diseases. We have a lot of members of major neurological diseases. These are the local groups, some involving people from nationally as well. And we've involved lots of collaboration with various groups over the years. What about achievements? Medway Skylarks has been encouraging singing for people, particularly with neurological disease and particularly with Parkinson's disease, for many years. That's now under Music for Wellbeing, but that was a very important thing, and we were also involved in the Neurological Alliance parliamentary reception back last year. This year we had a Rare Diseases Day at Jaspers. We've been involved in the Medway Non-Visible Disability Initiative. We had a Neurotech Day here on the campus here at the end of last year. Neurocafes are meeting monthly. This is an opportunity for people with specific diseases to have an opportunity to meet with others and meet with perhaps the charity that's involved so they can get more advice and support. And the Parkinson's Centre for Integrated Therapy is based at the University of Kent in Canterbury, but we're looking at having more and more collaboration. So what's the problem with neurology? This is international. There are 11.1 million deaths from neurological disease. Now, this is slightly confusing for if we look at Britain because dementia and stroke are counted as neurological diseases in every other country other than the UK, as far as I'm, it's a neurological disease. Second cause of global deaths. First in disability. And 43% of the world's population have something affecting their nervous condition or affected by that. So it's a large number. We talked earlier of the 1 in 6. In the UK, 1 in 6 people are affected by neurological disease. More recently, in the last couple of years, the World Health Organization had the Intersectorial Global Action Plan on epilepsy and other neurological disorders, really to improve the care and quality of life. And there is a toolkit which is supposed to be at national, but can be at local level, even hospital level, or now neighbourhood level, to see what is happening. So I think this is internationally showing the international importance of neurology. And what the IGAP talks of is raising policy prioritisation. Have we got a neurological plan? Do we provide effective, timely, responsive diagnosis, treatment and care? Are there policies for promotion and prevention? Do we foster research? Do we strengthen public health approach, particularly to epilepsy? This varies country to country. In large parts of Africa, still epilepsy is seen as a very stigmatizing illness that people, A, don't go out, and B, can't get medication. Their national aspects, the getting it right first time, talked of that looking at having more consultation remotely, that the patient can trigger their follow-up, that there is more time to follow up for specific diseases. So at least a Parkinson's disease patient should see a neurologist every year to check their medication. Better triage. It's now not, having not gone, it's now going too fast. Looking at time for those aspects, and nurse specialists being much more involved and multidisciplinary team being involved. There's the Specialised Neurology Services Service Specification last year, which again talked of timely access to treatments. And this year, the National Neurology Transformation Meeting saying that neurology is a priority, that we need to have better data, we need to have a workforce of 1.6 neurologists per 100,000, and my maths comes out at something like 5 to 6 neurologists for Medway. I don't think we're quite there. Voluntary and sector involvement, like including organisations like the MNN, and very importantly, mental health integration. We have very limited neuropsychiatry and neuropsychology in Medway. And when a survey was done a few years ago, we performed lower than the national average on all things. So time for appointment was lower. Knowing a contact wasn't as good. Care wasn't not meeting the needs. So there are real problems. Now, obviously, we've just mentioned neighbourhood health. Talking about moving things into the community, and we'll come back to that we think neurology is a good example of a possibility of doing that and reducing hospital attendances. I think there are big issues. The multidisciplinary team, NICE, and this is where I put my conflicts of interest. I chaired the NICE guidance on motor neurone disease, and there was a strong recommendation for multidisciplinary team care that was cost effective. It saves money, and people live longer with multidisciplinary team than they do if they see a neurologist. That's better than any drug. And I can't see that that affects any of the other long-term progressive diseases. I'm sure the same would happen, because what the multidisciplinary team does is the members of the team discussing patients, coming back and saying, I think that person needs the speech therapist. I think that person would benefit from seeing the doctor. So it's improving care. For local clinics, we've discussed and talked about neurohubs for at least 7 or 8 years. This with the idea to have a disease-related clinic in a health centre in the community where the speech therapist and physiotherapist could be. So instead of going out to see 6 people around the whole of Medway and spending a day doing that, they could spend an afternoon seeing 8 people in a clinic. It's obviously easier for patients and families. We hear again and again of the issues, particularly if someone is referred to a specialist clinic in London for a 9 o'clock appointment, they may be getting up at 4 o'clock in the morning. And then the doctors and everyone at the clinic wonders why they look so tired. And it allows professionals to have that coordinated approach. We talked about neurology, that we need perhaps more clinics, more neurologists to have time for that multidisciplinary team meetings and the hub clinics, and increasing that collaboration. And having professionals able to provide ongoing support. Again, that was in the NICE guidance, because so often a speech therapist may see someone for 2 or 3 times, then they're discharged. It takes weeks to see it get re-referred. They see a different person and have to go right the way back to the beginning, whereas if there was ability to come back to the same person. And mental health support, neuropsychiatry and neuropsychology are lacking in this area. There are issues about equipment, delays in equipment. Is it appropriate? Again, in the NICE guidance, we said, rather than give 4 wheelchairs over a period of 3 years, none of which are quite right, could we give 1 wheelchair on day 1 that can be adapted over the 4 years? It would seem better for the person and a darn sight cheaper. Disabled facilities grants. Are there fast track for diseases? Is there means testing? The cap, does it need to be increased? And palliative care, I'm sorry, I have to bring that on. Conflict of interest, I know, but is neurological care included within contracts with the Wisdom Hospice and the Wisdom Hospice services? Because I think enabling end-of-life care plans and advanced care planning is really essential for neurological patients, but it requires training of the professionals. It takes time, and it's got to be, if you've done it at home and you appear in hospital, everyone in the hospital knows exactly what you discussed at home. I know that's a challenge for everything at the moment. So the future, looking at community services, looking at the neuro hubs, looking at community team, looking at that coordinating that care between hospital and community and health and social care. And I think from the MNN to say we have the Medway Neurological Network and there are charities that are involved in our network, please include us in the plans. So perhaps when you're looking at the neighbourhood plans, can something come to the MNN so we can say, yes, we love this bit, this would help it. So I think that's one of the important areas that we would like to see as well. There's our information. I'll leave that up. So people can get in touch with us. We're very happy. And I kept it short because Teresa said they'd like to have some opportunities for discussion. Thank you.
Thank you very much, David. And absolutely, that's the important part of this while we've got people together. Can I just comment on a couple of things? There does seem to be a dissonance, doesn't there, with the way that dementia is regarded, dementia and stroke are not regarded in the UK. as neurological diseases, and it isn't something that I don't understand, whether you can enlighten us on why you think that there has been a reluctance to do that. And just to say, on disabled facilities grants, and Yasmin, I don't, this is something perhaps to take back. Several times, very sadly, and I've been contacted by people with motor neuron disease who simply can't get the adaptations quickly enough. And I know that the motor neuron disease lobby and charity are sort of, asking for an exception to this. And I think we have done some work on trying to make that happen. If you can't answer the question, it doesn't matter, but perhaps, if you can't, then come forward with a brick, because that is something that I think is entirely in the gift of the council to change and move forward on. And I know it's a source of enormous sadness and frustration for families, particularly, actually, in one case I've seen over the last year of somebody who really wanted to continue to work and could do so from home if the adaptations had been in place and there could have been exceptional disregard of other parts of their income. So that definitely is something for us. And, thank you for that presentation, David. I hope that people, have got a very clear idea there of the frustrations and challenges and asks from sufferers of neurological diseases. So I'll go to Yasmin just to see if you can help us on that, and then open up for any other questions.
So we're currently looking at the DFG pathway. So as part of my role as the head of early help and prevention, the OT service sits well within my service area. So we are looking at the DFG process at the moment, and in partnership with housing. What I can do is I can bring back some further information if that's helpful.
I think a briefing note on what we're doing, and perhaps Jill, you could work with Yasmin on that, particularly because we are looking further and deeper into the way that we supply accommodation when people's needs change, and having an overall review of supported housing. So I think if those two things as an action can come together, that would be helpful. Okay.
Can I just come back? I mean, it's a sort of national neurology elderly care physician debates about stroke and dementia. But I think you can't separate dementia from any part of medicine now, and people will have dementia as part of Parkinson's disease, with Lewy body dementia affecting many, many people with Parkinson's disease. And in motor neuron disease, temporal dementia is 15%. So there is an overlap. The need for neuropsychiatry and neuropsychology is probably even more than with dementia, because you're having someone who has other issues as well as their dementia, and physical issues, and trying to cope with that. Coming back on the grant, I support MND Association pushing that, but you can have someone with multiple systems atrophy who's just as disabled, just as likely to die in the next 2 or 3 years. And if it's fast track for MND, they are disadvantaged. And I think it needs to be on need rather than necessarily on diagnosis or a stage of disease. And it may be that MND would say, actually, from diagnosis, we're into serious stage, whereas MSA, it might be after 3 or 4 years, but there will be a time where other disease groups will be just as disadvantaged.
David, that's helpful. Anyone else, please? Dominic, were you coming? Yep.
Yep, I can come in. So it's just a reflection on really helpful, really great presentation. Really just reflecting on your point, which is the power of the MDTs. Because I think we do need to bring that to life with neighbourhood health, and we talk about these words, but actually that is underpinned by more proactive MDT working, or it needs to be, doesn't it, to be successful. So I think we need to reflect on that and the design of that, and happy that we involve and engage you in how we do that and in the development of it. because that is only going to work, neighbourhood health is only going to be successful if we do have effective MDT working and all professionals and partners working together. So I think we just need that really powerful, how you said, you know, I'm reflecting on how we make that happen.
Those who don't know me, I'm a local GP, but the other part of my life is that I represent the UK in Europe to do with neurological conditions. I'm a board member of the European Federation of Neurological Association, so I can give you a slightly broader picture. And David talked earlier about the WHO IGAP, Intergovernmental Action Plan. And it is interesting, the UK is behind already, even though it hasn't been there very long. And this seems to be repeated pattern, to be honest with you. If you look at other countries, they've moved from saying neurology to brain health. So you then don't get tied up in all that problem about, is it psychiatry, is it neurology, and so on. But they have national brain health plans in Finland, in Italy, and multiple other places. Now, I'm cynical, but I do think sometimes we take a long time to do this on a national basis, which is why I recommend we actually look at whether we can do something similar in Medway as a Medway-wide basis, or multi-neighbourhood basis, because I think that makes a difference. The other one is I really do think, I'm keen on neighbourhoods, and I'm very pleased to see that the negotiation on the GP side is going to mean that the primary care networks are going to go forward, albeit turning into neighbourhoods. But this is a perfect opportunity to do that famous left shift into the community, to put services closer to people, to take things out of hospital. I remember when I was doing fund holding a long, long time ago, we brought consultants out into the practices and they did things. They actually quite liked it. At first they were a bit nervous, but they did that. You know, you don't need to be sitting in a hospital to actually be doing a basic consultation. And now we've got community resources to do investigations, MRI scans and all that sort of thing. The argument about, well, you can't do it in the community because we haven't got the kit no longer applies. So all I'd say is have a look at it. Also, even though it's 1 in 6, the number of people who need a lot of intervention is lower than things like diabetes and that side. So it's a good way of piloting perhaps a neighbourhood approach as you go forward. Thank you.
And my comment follows on directly from what you just said, Julian, and that was to do with the lack of local clinics. And I can absolutely see the difficulty of families, carers, having to travel up to London using public transport. It takes up a lot of time, it takes money, particularly with people who've got neurodiverse disease. And so my question was really around, why don't we have these local clinics? Is it to do with lack of specialised healthcare staff, that we don't have enough to come into the communities? Are there wider barriers? And I was going to go on to ask, can we link up with the neighbourhood plans in this? Because I can absolutely see the huge benefit that having more localised services would have for our residents here.
I think back when, you know, with multidisciplinary teams, in Cambridge at one stage, there were 7 neurologists all seeing 2 people with motor neurone disease every year. And 2 of them said, we'll do it all. So instead of only, seeing 1 person every year, two of them saw 5 to 10 every year, and they built the expertise. And then they could have a speech therapist who had the expertise in the clinic, and a physiotherapist, and everything improved. And I think with things like speech therapy, rather than 10 speech therapists all seeing 1 person with a neurological disease, if 2 saw most of them, they build up the expertise, as well as the patients and families having the confidence in that person. And they can also start linking in with other groups, other charity groups who might support that. Because it may be an association would provide a speech therapy equipment quicker and easier and specific for that disease group. So I think it's that sort of concentrating in not just 1 person, because if you concentrate in 1 person, they're off sick the next day. You have to have 2, so you've got the cover. But to have that sort of link, and that's what multidisciplinary teams probably enable.
I mean, just perhaps if you're coming back, Dominic, and I've seen you, Eddie, thank you. I mean, that is supposed to be at the heart of neighbourhood health. The idea that particularly for specialist conditions, there would be a drawing on the resource in its entirety, as opposed to relying on small teams to go to lots of different places to see particular people. And you and Julian are both advocating for those changed ways of working, you know, which don't seem beyond the wit of anybody, do they? That things have developed in the way that they've developed for different reasons. But it's sounding to me as if, you know, there would be a willingness within the neurological professional community to change things. And I think as well, you know, there's an element of training, isn't there? For people who work in more generalist situations, such as speech therapists and indeed physical therapists, to spot these differences and changes. And I think in answer to Tracy's question, which we haven't sort of really answered, I think sometimes, you know, and I mentioned it earlier, this drive towards specialism and the idea that, you know, in a specialist centre, there's a greater breadth of pathology, that it is very attractive to practitioners. It is based on a bit of an outdated model because of what you said, Julian, because actually the kit and the equipment has changed and it's available in lots of different places more easily anyway. But the kind of system of delivering on it hasn't caught up. And, you know, it's interesting and very insightful to hear that. Dominic, you were coming back, and then Eddie, please.
Yeah, thank you. Just, I suppose, the reflection, and David started to talk about sort of the different levels, and so the starting off in primary care and then the single neighbourhood. But then I think what we're talking now about is the multi-neighbourhood, which is potentially 250,000, 250,000, when you can start to then look at the scale, can't you, of staffing and equipment and across a larger patch. I think that fit is really fitting in terms of what we're thinking moving forward, and it's how you use a resource, some of which may be at practice level, but then look at it across a wider geography to make a bigger impact. So I think there's, we can work that through the neighbourhood health, definitely. Yeah.
And I think if I might say, sorry, I hadn't turned my mic off, but I hope people heard you, Dominic. What we need to do for our population is make sure that they can understand it. You know, they will not be interested in what are essentially issues of governance and capacity, but they will be interested in knowing where they're supposed to go. And I think that isn't, at the moment, particularly easy to navigate. And it's a refreshed opportunity to make that happen. Ed?
Yeah, I beg forgiveness in the beginning because I might be demonstrating my lack of knowledge of the subject. So I've got a couple of questions. The first one, really basic. You referred to the multidisciplinary team, for instance, speech therapists. Can you expand a bit more? What is the likely composition of that team, please?
I mean, it will vary, but the aim would be to have the doctor, a nurse, physiotherapist, probably occupational therapist, speech therapist, perhaps dietitian, and maybe psychology or a social worker for, because there would also be the social aspects of, am I getting my right benefits? Can I apply for a grant for changing my house so I can carry on being at home? So all those people would have more understanding and training in neurology diseases, and probably in one or two specific ones for each clinic, so that they know if someone says, I've got this, they say, oh, yeah, that's not uncommon. We know about that, but I can't do that, but the person in the next room, or I'll give her a ring and she'll pop out and see you tomorrow. So it's that sort of really close interaction.
Yeah, thank you. I mean, that sounds like a really good idea. And it makes me wonder, because forgive me if I got it wrong, referencing like this is almost a new idea, so that begs the question, what happened before? Obviously, with a team like that, that's a lot of input and that's quite a significant cost. You did say, David, that there needs to be, forgive me if I got this wrong, a diagnostic need approach. So again, how was it approached before? So these are my thoughts, I'm saying them out loud. Has there actually been a change in outlook, as in the approach to the subjects? Was it a case of things were always done this way? So I think there can be with a small c, a conservatism amongst some groups, specialists. I know that, don't touch my area of expertise. Who do you think you are? This is my remit and leave me alone. If I'm talking nonsense, just tell me, but I'm just wondering if that's what's happened, is the impression I get. So are you actually, the ambition seems to be that you actually do want to try and do things differently, am I correct?
I mean, certainly it is looking at things differently. Some of the things are very basic, like someone with Parkinson's disease seeing a neurologist every 12 months and probably a specialist nurse every 6 months, in the 6 months in between, so that they are monitored, they can go. But at the same time, that patient can also ring up and say, I'm worse. I had an appointment 3 weeks ago, but I'm worse now. I can't wait 49 weeks to my next appointment. I need something now. And I think that's crucial. And that is working in a different way, because it has been, here's your appointment, we'll see you again in X months. And it should be that I can come back just for some advice. It may be to the specialist nurse who would say, that sounds more than I can deal with, let's get you to see the doctor. Or does the physiotherapist need to help out with that? It might be and it's that links and building up those links.
Okay, thank you. This sounds all really, really good, but it's a lot to put in place, isn't it? It's a lot of people buying into this cooperative approach.
I think it's all happening. We have, say, 100 patients, all seeing a speech therapist, seeing an occupational therapist, seeing a physiotherapist, and seeing a specialist nurse, but it's all haphazard. So actually, all those people are spending 50% of their time going across the area, going from one to other, whereas if they still need to do some visiting at home, but if there was a clinic the second Thursday of the month was MND and Parkinson's at Raynham, people could say, I can go in there and I'll see. So it won't actually necessarily increase the number. It might actually, it just rationalises it.
Thank you both. I think that this navigability is critical, and it hasn't been there before, and we've got an opportunity under Neighbourhood Health to make it happen and to, offer clarity in a way that wasn't possible. And if we take the new health centre, and there's plenty of capacity actually in some of the older healthy living centres for the kind of co-location that can make that happen, with our public health teams, with our own council teams who can help with, as Yasmin has said, elements that involve adult social care, elements that involve benefits, because actually, for some neurological conditions, people's needs change quite quickly. And it's really important to be responsive to that. And, it's good to hear that there's a willingness. It's about putting the system in position to make that happen, I think, Eddie. Adam, please. And then I'm going to, sorry, and Scott, actually, yeah. Then I'm going to, did you want to come back, Julian? No, you're
Well, the comment I was going to make is at the moment we have a multidisciplinary bus route with a different specialist at each of the bus stops. What we really want is a one-stop shop that puts it all together. And it is happening in other specialities. And like David, I was on a NICE guideline group. I wasn't the chairman. In a completely different field. And again, we recommended multidisciplinary teams because there's evidence that you get better care, fewer errors, and all sorts of things. And so facilitating that out in the community is the secret, putting them all together and getting them working together.
So Adam and then Scott, and then I'm going to close this item.
Yeah. Okay, first of all, I just wanted to say thank you very much for the presentation, and I like the way that over the last few years you have moved towards developing the Medway Neurological Network, because it's by working with like-minded people across the network within our Medway that we get the best way of being able to move forward our night services. I just wanted to put that perspective in because it was great seeing all those names of those different organisations within Medway that are, that are somehow linked in there. And there is an element there of, with your, MDS team, going out to where the community is, rather than having to set something up. So, for instance, many people know that I'm a trustee at the Sunlight Centre, and we have a weekly, dementia day there whereby the carers and like dementia like sufferers can go along and have a good afternoon socialising, and it's really important, particularly for carers, to be able to be amongst their peers in order to be able to pick up like developments, awareness of access to like certain services. And also things do change during the pattern of the like conditions. So I remember about 15 years ago, there was a lady who ran the like dementia group we had at the Sunlight Centre. Well, actually, no, she was a user because she came with her husband who had like dementia. He then passed away, so then she got involved voluntarily in terms of running that group, and then sadly she herself got like dementia. But there was another group that we could call upon. So through the Masons, we were able to get hold of someone who's very active in terms of running these groups to be able to come along to run that group. And the latest update is we've managed to apply for funding to be able to employ our own member of staff that can actually take on the management of that service, doing the kind of things that you're talking about, linking up with the like multidisciplinary team. And also just to say, never underestimate the power of the like support that you can get from the different age groups. So one of the best times of year at the Sunlight Centre with the dementia group is when the pupils come prior to Christmas to be able to sing carols to that group. And it's even got to the stage now whereby they went away again, and because the people organising that group had got enough gifts for them, knowing that they were going to be coming on to do the singing, they went back to the class and they came back within 20 minutes, half an hour, with their teachers, with cards that they'd written in their classroom, like with enough like for the people who were in that hall. And so that's that power of the like humanity. And the younger age group might have grandparents that might be suffering this, but it's there is a great power that comes from the actual like community. And the whole way that the Sunlight Centre was set up, which actually fits in with the Marmot Place like principles, is that it's being able to like provide somewhere where people can come and organise what they feel is needed by the like community, rather than necessarily centres saying we're going to do this because it's the right thing to do. If you can have it as much as possible like community driven, then that also fits in with your network principle as well. Thank you very much.
Scott, please.
Thank you. Just a simple suggestion, which I don't underestimate the complexity of a simple suggestion that I'm making. And the suggestion is very identical to the one when I was in the same room with Martin and Phil probably 7 years ago talking to CCG colleagues, whereby we have pretty much half-empty health living centres. And I don't want to add to your workload, Dominic, and kind of underestimate that. But the under-occupancy there is underwritten by our ICB. So absolutely maximising that for a hub, or one of those spaces for a hub for this condition, another condition, just makes absolute a no-brainer to us. We've got the professionals in to do it, we've got the need, we've got the physical locations. We absolutely need to revisit that contract arrangement with those centres and realise what we already have.
Yes, it is open on that one, please, Dominic, because it affects actually a huge amount of the work that we do, and I didn't feel under the CCG and in the early incarnation of the ICB that anybody got on top of property. So, Scott's absolutely right about that. Well, David and everybody from, and Julian and Martin and Phil from the Neurological Network, I hope that you feel your cares and concerns have been taken seriously and that this is a good time to have come along to the board. And I think that, a strong undertaking there from Dominic and from others to make sure that you continue to be involved, and a promise that Yasmin will come back to you with some of the things that we're doing on disability grants with help from Jill's team in housing. Okay, everybody happy to note the report with, I think, the very useful conversations and ideas that have come out from it. It was nice to see you, and let's stay in touch through Neighbourhood Health, please. Okay, I'll come to our last substantive item. I'm aware we haven't got a break, but Scott needs to go at 4, and I think if it's okay, we can, don't want to blame him only. He would be allowed to go anyway, but I think we can push through, welcoming Rob Kennedy from Kindy, our wholly owned council company that deals with assistive technology. And again, lots of links from what you will hear Rob say today with the issues that you've raised. And, you know, with Kindy's willingness to be fully embedded in neighbourhood health to make sure that the offer of assistive technology helps us continue to modernise, work on keeping people independent for longer, and giving families and carers the assurance they need that their loved ones are well looked after. And you'll see some fantastic kit, some great pictures, and I do pay tribute to Rob and the team, who I just said to him when he came in today, I think I've seen him practically every day for the last fortnight at one event or another. They really are out there in the community explaining to people what's available, which is half the battle. And remember, if you've got a Ring doorbell or Alexa, you're on the way with assistive technology. It's not something that is strange or unusual. It's something that, you know, all households can make use of. So with that, Rob, I'll pass over to you.
Brilliant. Thank you very much, everybody. So this is really just a little bit of an awareness session for what we are and what we do. A lot of people we've crossed, the MNN we support and everything like that. So as Teresa says, we are out around in the community all the time. So just a bit with regard to how our mission and vision underpins what we do in our day-to-day activities. So we aim, obviously, to provide compassionate, personalised services that assist individuals to live their best lives possible. And we aim for a world where every individual, regardless of age or ability, can live safely with confidence, independence and dignity, supported by technology that truly cares and actually fits them. So what we do. So what we do now, so we offer person-led technology. And what our team do is they start by listening to each individual's goals and preferences, and we ensure the support is wrapped around them. Through their empathy, they build relationships based on the understanding and dignity and make sure that the technology feels supportive rather than intrusive. We focus on accessibility, ensuring solutions are easy to use, inclusive and adaptable. And finally, our drive for innovation keeps them at the forefront of assistive technology, using creative, forward-thinking tools that empower individuals to live while staying connected to the people and support that they trust. So why was a review needed? So everyone knows what telecare was in the past. Reactive telecare is outmoded. However, there is still a definite use for it. It was often introduced far too late. There was a low utilisation and a poor fit with everyday life, with many older adults who had it installed. The switch over at the moment that's going along from analogue to digital has made it unreliable and obsolete. And our NHS prevention agenda requires us to move towards a more proactive and data-enabled support instead. The newer technologies that we look out for every day offer early detection, safety and independence, which was not possible previously with reactive alarms. So our new AT and our prevention supports the NHS prevention agenda. It identifies and monitors early users. It empowers self-management. It reduces pressure on services and supports integration. The benefits are improved independence and quality of life, fewer unplanned hospital admissions, lower longer-term care costs, and more efficient use of workplace capacity. So we use these 3 pillars and 3 stages. So we assess, we go to people's houses and we do in-house evaluations. We speak to the family as well as the individual if they so wish, and we recommend suitable technologies. We then implement them. We do the installation, so the same team that assess do the installing, and we train the clients and the family members on how to use it, and we customise alerts and reports for individuals' needs. And then we define the outcomes, so we collaborate with Medway Adult Social Care and hospital discharge teams. This enables us to move quickly to enable safer, faster discharges reduce hospital readmissions and promote independent living. So I'm very proud of our team of 7 care technologists that we trained with support from the NCF. We were the first area to have the care technologists. They were the first ones qualified, and they've formed the curriculum for it going forward. These people are based out of Medway Hospital, but also operate along the community and in our neighbouring boroughs. They carry out the person-led assessments. They build trust and accessibility. They coordinate a holistic support and signpost, and then they arrange behaviour data analysis and identify risks in an early and timely fashion to support ongoing safety and well-being. We then measure the impact. So our impact measures quality of life for the individual, quality of life for the carers to reduce stress and support paid carers. We look at the social impact to reduce isolation. We try to encourage community engagement, and then we save money for care costs and avoided hospital admissions, and costs being saved for the individuals as well who are having to fund these themselves. So we use these success metrics: individual outcomes, independence, reduce crises and improve well-being, reduce stress and greater reassurance for unpaid carers, increased efficiency for paid carers, safer working and fewer unnecessary visits. Social impact, we aim to reduce isolation, encourage community engagement. We operate in an agile fashion, fast, end-to-end quality and interoperable systems, which means everything talks to each other within our new control centre at Gunwharf. Financial savings, fewer admissions, reduced care costs and clear cost avoidance. So why are we different from other companies delivering this? So we're a LATCO, which means we sit outside, just outside the council, the local authority, which enables us to make quick decisions, which is reflective of the need of a technology and the technology situation that's moving so quickly. We have full control from the process of the assessment to ongoing reviews. We've got our own alarm receiving centre, which we can manipulate, some of the operators would say, to encompass some of the new technologies that we bring on board, but handles reactive and preventative alerts 24/7, 365. And we gather holistic data from all these sources and report back to the family, to the individuals themselves, and to all the relevant professionals who have engaged with us. So now, just a few bits of new tech we've introduced over the last 18 months. A lot of you would have seen some of these, and some of the bits of equipment you probably wouldn't have done. So this is Anna, the medication dispensing adherence robot. This has been going for about 18 months. We've got 100 deployed across Medway. We've increased medication adherence from 44% in these cases up to 98.9%. It operates as a not a walk-in, it looks a bit like an air fryer, but it holds a dossier of pills that reflect the prescription, sits in the back of the, it comes out in pouches, sits in the back of the machine. Barcodes are read. When the medication is due, the machine lights up, talks to the individual, or flashes. Press the button, you take the medication. If the medication button isn't pressed within a set period of time, it drops through and is locked away. And then Anna will send messages and emails to the control centre, but also to family and carers, which show that the medication hasn't been taken, particularly initially launched for people with challenges with Parkinson's, where medication is key and when it needs to be taken is key. This has supported them massively with this, but it's also worked across everything within the community, from young adults through to people suffering from dementia, to people just journeying in general with general health conditions.
The abundance is a medication adherence device in the form of a robot. The benefit for our service users is that it provides them with the independence to take the right medication at the right time, in the right dosage, to enable them to live independently at home without having to rely on carers coming in at certain times, which impacts their lifestyle. My initial conversations with John was that he wished to live as independently as possible, and one of his goals was to be able to travel seaside for a couple of days away from the caravan. Now, the situation he was living in, he wasn't able to do that. The Avendos machine has enabled him to kind of fulfill that way, so he's able to move out 24 hours and to step down, which gives him some autonomy, more independent living, but it's also enabled him to travel. He can take his Avendos machine with him to the caravan to fulfill his dream of being able to do that as he did as a child.
It's become essential for our service users just because of the ease of it. It alerts them when the medication is due. They press the button and they can take the medication.
So at his old place, the staff were told to give him his tablets twice a day, and we were concerned that when he moved to this place that he wouldn't be able to take his tablets on his own. But since day one, the Bondos being installed, it's been working really well.
The other benefits for John using the Avendos machine is his relationship with his family. They've always been really supportive, but the video aspect of it has really enabled him to build a more frequent and regular relationship with his sister.
I thought the installation was really easy because it's like a round machine, portable, they program it and then just plug it in the wall and then that's it.
If anyone's interested in having the Avendos for themselves or for a loved one, all they need to do is visit the website or send us an email and we'll get in contact to go through the process. The medication dispenser, we have the circadian light bulb, which is a smart light bulb, which sits in a normal fitting. It's really good for sleep promotion. It gets lighter during the day and then calms down to a calmer night at night to promote sleep. It also has sensors around it, which acoustic sensors, which can highlight coughing, snoring, sounds of distress, and we monitor all of that. So it's really good we've got a few out in some residential care settings, but we've also got about 130 across the community. And again, it's supporting a real huge range of people from youngsters, people with autism, Down syndrome, through to people with dementia and Parkinson's. It's giving them that ability because it's promoting their sleep. They're more engaged during the day. They can go out in community activities. Just a bit more about the circadian light. Straight. And again. Yeah. And then what we have is our Andy device, which is a traditional lifeline, but it connects to a number of different sensors, including Ring doorbells and Alexas. It also has the sensor-based technology within it so that you can measure activities of daily living. You can measure usage of kettles, fridges, use of a bathroom, and it builds up a picture of how people live their lives. And we deliver it by continuous assessment, proactive and preventative insight, and integrated reactive safety. So I said that's fine. And this is how it does it all, and who it links to, which is a huge gamut of individual devices. One of the latest bits of tech is we've got some smart socks developed with the Alzheimer's Society. We're the first people within the UK to actually trial this in the community. The little box you see on the side measures rising in anxiety through sweat secretions. I know that sounds a bit bad, but people with increasing anxiety sometimes is a trigger for seizures or a trigger for challenging behaviours. That will send alerts to carers in care homes or family or to our control centre if that's getting too high. And we know because we've done the person-led assessment, we can then use that to decide where that trigger is going to be. We can also do it retrospectively and create a report that says, okay, that this person's behaviours were worsened at this time, and this is where it shows on the machine. It also measures gait. So if someone's walking pattern is decreasing or changing, then that sometimes is a frailty indicator. So it will do that as well. So yeah, this is in proof of concept stage, but is working really well at the moment. And the benefit of having these more youthful technologies is that we can mould how they develop. You've probably all seen this with the Kent and Medway virtual house that we refresh every 6 months. It's on the Medway Council website, it's on the Kindy website, You can go in, you can walk around as if you're buying the property, but all the little buttons there show occupational therapy tools, and all our devices are in there as well, and how you can access it. It's completely free to access, it's open to anybody, whereas certain organisations that won't be mentioned charge you to access their virtual house. We don't. You can see there the radio buttons, it tells you a little bit more information about that. And yeah, here endeth the sermon, I believe. So we're very happy to have a conversation outside of this, but and I take any questions.
Thank you very much, Rob. And in your own time, do watch the video about the circadian light bulb, because it's actually quite moving and shows how useful it is. And, you know, all of these devices are collecting data, and that data can be shared. So picking up early changes, early deterioration, improvements, you know, are all possible. And we've done a lot, Rob's done a lot with our adult social care team, coming to our all-division meetings, bringing all the equipment, because it's not the case that every social worker who's carrying out assessments has seen this stuff or knows how to work, so we're building professional confidence and modernisation. I was very lucky to chair a parliamentary commission on assistive technology with Policy Connect that Kindy sponsored. We've got a great report from that with actions which we're using to monitor the efficacy of Kindy itself. And, you know, for me, this is a demonstration not only of the way that we can keep people independent and safe for longer, but also the way that the industry is changing and has the potential to really attract more people, because we've got an ageing workforce, particularly in direct care, you know, for younger people using this tech. And I've seen it myself across the colleges. They're not scared. They don't, you know, worry about pressing the button. They get straight in. I've seen, you know, young people working with a group of older people, playing games that are projected onto a table as opposed to being physical pieces of a board game where you use your hand to move, or another piece of equipment if it's difficult for you to use your hand. There's a lot of soothing robots and things that, you know, and I don't mean sort of, you know, E.T. type robots, but you know, rabbits and dogs and cats that breathe and give people a bit of comfort. There's a huge area of assistive technology that is putting social care on the map of a very, very serious part of economic growth and potential. And that is as important as all of the benefits that it's bringing to the people that we care for. And Kindy are doing a great job, very embedded with the colleges across Kent on this, coming along and doing demonstrations. And as I say, to our own staff and to anybody here who thinks that, you know, your groups could benefit from a demonstration. Because I think once people see it and see how easy it is to use and understand how to access it, they, you know, I haven't met people who regret it. And I do think, you know, it's a great tribute, Rob, to you and your team for the way that you go out in a very relatable, kindly way directly into people's homes. I've made, any councillor can do this, a direct referral to anyone you're worried about it in your ward. That's work too. And Adam, as you've told us, coming along to groups to demonstrate this so that carers can see, you know, all of that is part of Kindy's work, as well as being a leading company now in the use and, you know, influencing the development of technology by dint of the people that we're using it with. Scott, please.
Thank you. It's really good to see, you know, how much comes on. Just a question in terms of clearly it's adding value to people's lives, and we'll add value to people's lives, you know, who need it at the right time, right equipment, right place. What's the biggest barrier to doing that? Is it general awareness for people to know it exists, and the trust and confidence, therefore, is the best thing we can do is make sure people have that, give you that warm lead so people can have the opportunity to see it? Is it funding because, you know, it comes with a cost that people can't afford? What's the biggest challenge of why everybody who needs it won't have one of these in their home, or some of these?
Yeah, good question, Scott. I mean, our biggest barrier is awareness. You say assistive tech, or you say telecare, or you say telehealth care, or all those different derivatives that were there when Claire and I first worked together 10, 12 years ago. and they just see it as a button in the box, and they have that stigma around that red button on, because, you know, we've grown up with it. My father-in-law, they don't want to wear that, but they wear a Fitbit or they wear an Apple Watch, and that does exactly the same thing. You know, that's the awareness that it's changed, and it's not that traditional tech. That's our biggest concern.
Yeah, thanks, Chair. I mean, it's great. Who doesn't love a bit of technology at a meeting like this? I was just wondering, the £35,000 number that you quote, for me, I'd expect adult social services to be queuing up at your door saying, save us £35,000 for each of these cases. But I'm just wondering how many referrals you've got from adult social care at the moment, and, you know, how long does it take to get the tech in? And the obvious question, for someone who might have to pay for the technology themselves, sort of any idea of the running costs of running? And I was just wondering, how much of this tech are you actually developing yourselves, or are you just researching, finding good tech, testing it, making sure it works, and then effectively sort of reselling it, as it were?
Thank you. I'll take the last question first, because I'll forget otherwise. None of it's our tech, but I sort of mentioned the newer generation tech is able to be manipulated to fit our requirements, our clients' requirements after we do co-production. So the socks have been changed since we first got them. They're now more adaptive. They've through their third gen since we started putting them out. So none of it we actually own the API for, but we are seen as a test bed across the country for new tech and across Europe. And again, not just hands up here, we as United Kingdom are so far behind, like the Baltic states, who are, you know, sort of light years ahead of us. So we were looking at that to be the good prime work. With regard to social care, as Chair said, we are now thoroughly embedded, and our referrals, well, when I first started, were 2-3 a week, now running at about 50, 60 a week for new tech. We started off with 10 circadian light bulbs. We're now about 160 within about 18 months. With regard to cost barriers, the majority of the newer tech is funded out of work that we're doing through the Better Care Fund. We do have private pay options for it. For example, the private pay option for a light bulb would be circa £10 a week. Doesn't cost any more to run. Once it's in your property, it's the same as a low energy light bulb. But that in itself, if that technology works and you can bring the circle of carers around so they can have that assessment tool, have the data, the individual can have it, it's probably worth the £10 a week. It's also that particular product is within the Mosaic prescribing function as well, so it can come off the personal budget going forward.
Thank you. And I think it's also worth saying, Andrew, because it's a good question that you asked, we're very embedded with our care providers who are on the council framework. They've had presentations. We meet them every month, and there's always a spot there. So it's starting to grow. Yes.
I was very quick. As a person with Parkinson's for 14 years, I'm very excited about the air fryer and just going to Eddie. I've got a small piece of tech on the back of my phone which allows me to speak, because I go to speech and language service, and because one of my symptoms of Parkinson's is fixed over voice. So technology is able to speak.
Thank you very much, Phil. Right, I've got Eddie, Claire, and then David Oliver.
Thank you, Chair. This your presentation really brought this item to life for me, and the timing of it. I read so much from different places. I read it might have been an advert stroke article. You know, when you get these sort of hybrids about circadian lighting. When I read it, my initial impression or reaction was, sounds too good to be true. So just cynical, I don't know why. However, as you're speaking, I can think of somebody, so when I was at work yesterday, sorry, this is for people with learning needs or mental health diagnosis or both. And I was pleasantly surprised that one of the residents came to the door. It's 3 o'clock in the afternoon. She's got dressed. Not only that, she's actually been out. The reason why I say this is that on average, she'll get up at some point in the middle of the afternoon. So the idea that any kind of lighting could help set some kind of better sleep patterns and whatever may be very productive. She will spend days and days in a dressing gown and socks and slippers, and she complains about her feet. So I also wondered about the socks. And the other one that really impressed me was your medicine machine, whatever that's called. The Evandos.
Air fryer works.
The air fryer, yeah. I still want to know if you can fry chips in it. So with some of the reasons we got, you've got to get this. I'm not saying this is a criticism. It's part of it can be. There's an attitude there, right? But even with somebody who knows, they recognise they need to take the medication, usually proactive. Oh, I'm not feeling very well. Why not? I forgot to take my medication. It's not because of bad attitude. They literally just goes out of their mind because they're not functioning. So the idea of any kind of technology that could help, this would be absolutely brilliant. However, will the company I work for want the expense? Because ultimately it's a business and it's all about profit margins. Having said that, can I have a quick word with you afterwards? Because if you can pass on to me something I can pass on to the team above me, we've had a change recently, by the way, and I've noticed a much more can-do, proactive attitude between the line management there. So, there's hope, you never know.
Thank you. And you're right, 12 years, it has moved on, the technology. I'm like, oh, wow. So I'm going to be cheeky and ask a few questions, if that's all right. So firstly, who aren't you reaching then? So it's fantastic, those referrals from social care. So who aren't you reaching? What are your sort of goals around? Who else needs to know about this? Because I'm guessing you know better than the rest of us who you need to reach. And then is it with this technology, does it always have to be monitored by the control centre, or are there options where family can monitor it themselves, so kind of independent view, but you just provide the tech? And then the third one is just what do you need? What do you need from us to sort of, because there's no doubt it has so many benefits, and that's not changed, but let's be really direct around what help is missing for you.
Thanks, Claire. Second question first, while I remember. No, that's the easiest one to answer. However they want it monitored, whether it's Care Circle, whether it's monitoring it with their loved ones, or whether it's a carer or professional carer or control centre, just be in the backup. Whichever way, whatever comes first, we can do. With regard to, what was the first question? Well, what aren't I reaching? Well, up until about 3 months ago, I wasn't reaching children's, but now we are, sort of. So we mirror the panel. We sit on a panel every Wednesday with one of the teams there, and we're looking at supporting them, because the technology translates well into that as well. And with regard to what do we need, whilst Chair said we are out and about in the community a lot, there are still underserved people. So we try and get out to the sort of the peninsulas that go to Grain and people like that, but there are still people who don't engage in the community, and we want to get to people that aren't in hospital. We get to them before hospital. So an ideal world would be us to go and see all the GPs and get their buy-in into the tech, whether it's through Kindia, whether it's through any other provider, but tech at that first primary contact is where that's going to really see that downstream effect knocking all the way through acute.
FAME team out and about doing falls prevention. We see about 800 people, hopefully before they fall. Have you spoke to them? Do you remember?
It would be brilliant too.
I'll link that.
Yeah, because for the FAME team, so our falls prevention groups, 800 and growing, there's about 14 groups, often have a cup of tea and chat session associated with the exercise, and it's a 20-week programme. So there's plenty of scope there. Rob and I should have thought of that, definitely. So thank you for that, Scott. Anybody else? Tim, thank you.
Oh, thank you, Chair, and thank you for the presentation. Wonderful to see the technology being utilised. My question is, as the tech has developed and more users are coming on board, I mean, even counting for the resistance of people who like more manual aspects of their care, will there come a breaking point where with the number of users you've got, there'll need to be a really significant investment or focus on the safeguards in order to protect that very sensitive data, and especially with a lot of the things being online, the risks of data hacking and other aspects like that?
Very valid point. So with the move to the new control centre at Gunwharf, we've put some added security measures in, but also any new product that we bring online has to go through a rigorous testing process with regard to our onboarding. We have our AI policy that it has to support. It's all published, and we ensure that all of part of the onboarding is that all of the servers are secure. They all have backup servers and fallover servers. We won't entertain a new product unless all of that due diligence has been done first. And yeah, so yes, there is always a danger. However, we try and put as much safeguarding in as possible before we start throwing the product out to the public.
Yeah, good question, Tim, but I'm very convinced that Kindy have got that covered. We had our shareholder board on Monday, actually, and in fact, we've got, apart from all of the technological safeguards, in-depth vetting of the people who work there. And actually, very sadly, we've had a couple of people recently fail the vetting, not for anything to do with themselves, but because of distant relatives. So it's the same level as being used in prisons and with the police, because you're absolutely right, it is a risk. But I'm satisfied, and the board was certainly satisfied that Kindy are across that. Mark Jones, please, as our last speaker.
Well, it was only going to be a quick question, Chair. A very interesting presentation. Services to other boroughs were mentioned. I just wondered, are these broadly neighbouring boroughs? Because whilst obviously we can't procure ahead of local government review, I'm just interested in the sort of areas that Kindy serves.
Yeah, thank you for that. With our positioning at the acute trust in Medway, we come across sort of 50% of the patients being from the Swale area. So we will serve them, but we'll serve them in a privately funded or signposting fashion. We look after some services for Gravesham Borough Council, and part of the fallout to that is that we supply some of the assisted tech to their residents. So yeah, it's a good, but they're close-knit.
So with that, thank you very much, Rob, to you and the team for your ongoing work. Some offers of help there through FAME, and I don't know if Julian can help with us getting to GPs. That would be, we'll certainly speak to Sook perhaps, but any sort of forums, training that Kindy can go to, I don't know if you can help us with that.
I can see what I can do. I think some reassurance to GPs, because a lot of people had their fingers burnt with the older technology. In particular, not false alerts, but for example, you'd have someone whose blood oxygen level would drop if they went up the stairs, but only for 10 minutes, but it triggered an alert at the practice, and so you come in the morning and see 10 alerts for various patients. So it's that side. It's using the AI, and the side is that the member of staff who has the most compliments at my practice is called Andy. It's an AI telephonist. No, it's true. If someone can't do the online questionnaire, it actually talks with them and does the questionnaire and so on. But we have so many patients who actually think they're talking to a real person.
Well, that is an insightful and perhaps a warning note to end on. Thank you, Rob, very much. Everybody happy to note the report, the Office of Help, and the ability to spread the word. Okay. Thank you. Last item then, please, Stephanie, our work programme.
I'll just be very brief. The next meeting is on the 3rd of September. We'll have a report from Scott with the themes that we'll be looking at for the next municipal year. We'll have an update on Marmot Place, a neighbourhood health plan from David, and we'll also have a paper on send reforms from Celia.
Okay, so thank you for your attendance, everybody. Look out for the summer engagement session. We'll work with you on that, Dominic, to make that happen. Thank you for your attendance, everybody, today. It was nice to see you.